like first thank you, Professor Mahmoud Salah and Professor Sachs, for inviting me here. Well, the task may be short because 90% of the facts were presented by my colleagues yesterday and today. As usually, there is a talk and discussion about management of infrarenal aneurysm, what is better or what is more suitable for the patient, open repair or EVAR, infrarenal EVAR. Well, looking at the historical background, I can say that neither of this method is novel right now because all of them, I mean open repair and endovascular repair, were invented in the last century, and we have enough data to compare it, but every year there are some comparisons, but there are no strict conclusions. What is better? They are parallel, in my opinion. Doesn't work. Can you move back? So, what aspects we need to compare when during the qualification process and during the decision what the method should be chosen in the patient we want to operate? Well, procedure type, hospital stay, recovery time, complications, durability of repair, quality of life, mortality rates, which is obvious and it is analyzed constantly, and more rare things like follow-up requirements, which are different, and of course treatment costs, which is also different and is country dependent. Type of procedure. Well, we know that EVAR is minimally invasive procedure and open repair is just standard open big abdominal operation. So the pros and cons are listed here. There is an improvement, of course, in open repair because we can significantly diminish the blood loss because of blood loss recovery devices we have. We can also support the patients from cardiac point of view during the clamping and declamping procedure, which is the most dangerous part during the operation. In the other hand, we have X-ray and contrast exposure to the patient, which is significant, especially during the follow-up. Hospital stay. Of course, patients who are treated with minimally invasive procedure like EVAR stay in the hospital shorter. The average is 3 days, sometimes 2 days if you use occluders. There are centers in the US making it 1-day procedure, but it is, for me, it's risky as a surgeon. Of course, it has pros like resources utilization. If you have a patient waiting, it's better to make 3 EVARs than something like 2 or 1 open repair because it's less time and resources consuming. Durability. This is an opposite situation. It is the EVAR offers short-term advantage, like lower mortality, but the durability is discussive. I mean, the last durability big study, not sponsored by industry, was EVAR 1, and then nothing more. So, but in general, I spoke to one surgeon from Chicago. He was an open surgeon for open repair. And he always says to me that if the patient comes for first control and asking him, how is he doing? He's doing well, everything is fine after open repair. The second question is, when can I come back? And he say, never, you're cured. It is not the situation in EVAR when we need a constant follow-up for lifetime, usually. So this is 10 studies concerning a short time or short period mortality. Of course, EVAR has a big advantage here. However, it changes during the time from the initial procedure. Of course, if we look at the chart bar, it looks impressive for EVAR, but during the time, it's not like that. So now we can analyze long-term analysis-related mortality, and these values are, for me, comparable. In EVAR, it's about 3%. Now, in open repair, it is about 3 to 4%. In my center, it's a little bit higher. It's 4.9 to open repair and comparable EVAR mean mortality. But I analyzed 3 last years. Because of COVID, I couldn't do analysis of 2020. So that's why I analyzed 3 last years. Overall mortality, that's tricky because all of our patients have at least one comorbidity, usually 3. Hypertension, MIC, very high percentage of diabetes, and of course renal failure. So the overall mortality cannot tell us anything about which method is better. Complications. OR complications are rare. They exist. In the table below, you can see mostly there are ischemic complications and hernias, secondary rupture. It's rather not very often. Of course, EVAR complications comes from the methods. So all endoleaks, all thrombotic events are connected with durability of the graft. So here, open repair is favorable comparing to EVAR. Treatment costs. This is tricky because it depends on country. If the procedure is fully reimbursed, open repair is, of course, in the long term, more cost-effective than EVAR. However, if the reimbursement is different, maybe EVAR. It's even in Europe, every country has different policy in reimbursement, so it's a different type of counting the cost of the treatment. Generally speaking, the substantial cost of the treatment of the patients after EVAR is the monitoring. I mean, gradually rising cost of CT scans and other procedures, and also reintervention, because reintervention's cost is much higher in EVAR than in open repair. This is what I said before, just follow-up requirements. In open surgical repair, ultrasound once a year, once at 2 years, after 5 years, it's enough. In EVAR, you can, according to guidelines, the CT scans is a standard, at least 1 a year, lifetime. So this is a big difference. Quality of life. During the first period, I mean the first 6 months, EVAR is better. But during the longer time, it's not so obvious because of the reinterventions rate. The quality of life parameters are nearly equal after 5 years. Well, conclusions. Benefits of EVAR are obvious. Minimally invasive procedure. If we have the patients with a lot of comorbidities, the first initial phase is very safe for him. If life expectancy of the patient is short, the EVAR is the method of choice. However, if we have young patients in 60s with low comorbidities, with long life expectancy, for me, open repair is much better option than EVAR. But, of course, the final decision is also the patient decision. I mean, the quality of life. If the patient doesn't want to have a big operation, we can consider EVAR. Well, thank you for your time.
Thank you very much for this comprehensive overview.